Well, I'll just do a quick introduction for you then. So Dr. Brandon Van Asseldonk is the newest member of a 4-person team at Scarborough Health Network in the vascular surgery group. He joined the group nearly 3 years ago following medical school and vascular surgery residency at the University of Toronto. Preceding this, he completed a medical engineering degree at the University of Waterloo and briefly worked at Apple in California as an engineer on the original Apple iWatch. I find that very interesting. His clinical interests span the full spectrum of vascular care and quality improvement, including management of peripheral artery disease and venous disease. So without any further ado, I'll turn it over to you. And thank you so much for being here, Dr. Van Asseldonk. We really appreciate it.
No problem. Can you hear me okay? Can you see my slides?
All is working well. Yeah, thank you.
Okay, perfect. If anything changes midway, just let me know and I will accommodate. So thanks for the kind introductions, and I appreciate the invitation to speak, and thank you everyone for your obviously valuable time on a prime Friday in June. So I'm a vascular surgeon, and my name's Brandon Van Asseldonk. So we'll just get started. I don't have any relevant disclosures. Nothing that we'll discuss today is off-label or experimental. The objectives for today's talk: we're going to talk about some common vascular pathologies. As I was preparing this talk, I was kind of thinking to myself, and obviously, my practice is exclusively vascular surgery, but for everyone here today, I suspect vascular surgery is probably a minority of your practice. So I'm hoping that I can impart some wisdom and knowledge and guidance that will help you when you see things that maybe you don't see quite as frequently as I do. And so we'll talk about common vascular pathologies, initial workup management, and talk about referral pathways as well. So as introduced, I work in Scarborough. I'm part of the SHN Vascular Surgery Group. This is a 4-person vascular surgery group in Scarborough. We provide services inpatient hospital services at a total of 4 hospitals. We cover the 3 Scarborough hospitals, the Scarborough General, the Scarborough Birchmount, and then the Scarborough Centenary Hospital, which I believe at one point in time was affiliated with Lakeridge, or there was. It certainly is the closest to Lakeridge. And then within the last 1 or 2 years, we also have an affiliation with North York General Hospital, where we provide services as well. So we're a fairly busy group. We're mainly based at Scarborough General Hospital, so McCowan and Lawrence. I think some unique things about our practice that I think are a real strong asset is we have a hospital-run wound clinic at Scarborough General, and it's a very busy clinic, and we have a lot of hospital and nursing support, which is great because it gives us the ability to deal with and to help manage a lot of kind of complex wounds. So for example, in clinic, we're able to measure ankle brachial indices right in clinic, so that helps us get compression therapy on quickly and not having to wait for kind of outpatient ultrasound results, which can take time. Our nurses and clinic staff are able to put on compression wraps right at the same visit, so it gets people kind of moving in their care. We're able to do debridements. Also kind of complex wound care, and we're able to initiate negative pressure wound therapy as well. And then, we have a multidisciplinary team. We have cast technicians, ortho techs. We have, our nursing staff. I work alongside a foot and ankle orthopedic surgeon and a plastic surgeon once weekly. So it's nice to be able to have colleagues nearby that, if somebody maybe needs to see the orthopedic surgeon more than they need to see me, they can see both of us in one visit, and saves patients time and repeat visits. So that's a strong asset. I wanted to highlight on this is a little bit kind of technical, but we recently opened a multi-million-dollar kind of hybrid operating room at Scarborough General, which was many, many years in the making, and very exciting for us here at Scarborough. You can kind of think of it like an amalgamation between a conventional operating room and an interventional radiology suite, so we can do everything, either the peripheral or the endovascular procedures or the open or even combined procedures. So it's a real welcome addition to our center. I wanted to talk a little bit about peripheral arterial disease, certainly a very common pathology that I see on a daily basis. Um, when we talk about peripheral arterial disease, the vast majority of it is secondary to atherosclerosis. Risk factors for that being aging, diabetes, smoking, hypertension, elevated cholesterol, chronic kidney disease, or end-stage renal disease on dialysis, whether it be peritoneal or hemodialysis, and low socioeconomic status. There are some kind of more rare and less common causes of occlusive disease, and these can include the sequelae of embolic disease, so from atrial fibrillation, probably the most common, iatrogenic, and there's some even more uncommon pathologies, popliteal entrapment, which is muscle compression of the popliteal artery, and cysts in the wall of the arteries as well. So I wanted to talk a little bit about screening for peripheral arterial disease. This is a question that sometimes comes up, and if you look at the guidelines, so the question is, do patients need screening for peripheral arterial disease? Is it evidence-based, and should we do it? And so this is really only a question for those who are entirely asymptomatic. And if you look at probably the two main guidelines that govern my practice, if you look at the Society for Vascular Surgery, they cite no benefit to screening. And if you look at the American Heart Administration, screening is a very weak recommendation. So I generally don't screen patients. I mean, obviously, I get referred patients, who often already have a diagnosis of PAD, but screening isn't something that needs to be done. But certainly if there are symptoms or a concern that the symptoms may be from peripheral arterial disease, that's obviously an entirely different question. But screening alone is not indicated. When we talk about making a diagnosis of peripheral arterial disease, I mean, obviously our history and physical exam are really the mainstays, certainly examining lower extremity pulses. When we look at imaging and, we're asking ourselves, is this patient's symptoms from peripheral arterial disease? Duplex arterial ultrasound is really the mainstay of diagnosis and even surveillance of peripheral arterial disease. Duplex means two, as we all know, but it means that they look at the wall they look at the structure of the artery, kind of what does the artery look like? Is there a big plaque in the middle of it? But they also look at blood flow through the artery as well. And they're able to measure a couple different parameters that help us understand what the perfusion to the foot is like. So these would be the ankle brachial index and the toe brachial index. They're similar tests. The ankle brachial index essentially involves putting a blood pressure cuff around the ankle and measuring the pressure down to the level of the ankle. And the toe brachial index is pretty much the exact same thing except to the toe. So you can see a photo there of somebody who's got essentially a tiny blood pressure cuff on their big toe, and that's exactly how the toe brachial index is measured. You say, why do we use these different measurements? Well, the ankle brachial index can sometimes be unreliable in people with very calcified arteries, like especially those with diabetes, chronic kidney disease, end-stage renal disease, and also with older age. And so sometimes toe brachial index is a bit more of an accurate measure. But really, duplex ultrasound is kind of the workhorse for diagnosis. CT angiogram is certainly an important test. In my practice and in my experience, it really is in the setting of peripheral arterial disease, it's really for an intervention planning. So it's not something that I order for diagnosis typically, outside of very kind of rare and isolated situations. And I don't think it's a really ideal first test certainly for the diagnosis of peripheral arterial disease. There certainly are limitations with CT angiogram. There's often disease is overcalled, so people overestimate the amount of disease on a CT angiogram. And a CT angiogram won't be able to tell you how much flow to the foot, or won't be able to give you an objective measurement of perfusion. And then additionally, when we look at the small blood vessels in the calf, a CT scan is not very good at seeing those, especially when there's calcification present, such as kidney disease or diabetes. So it's really a tool for surgical planning if and when surgery is indicated. when we talk about peripheral arterial disease, we classify patients into 3 different categories. First would be asymptomatic. So these would be people who have peripheral arterial disease on their duplex, on exam, but have no symptoms from that. And then as we move up in symptom severity and disease severity, we encounter those with claudication. And claudication is exercise-induced pain. Most commonly involves the calf. But it can involve the thigh and the buttock. It depends on where the vascular disease is. So if the vascular disease is higher up in the pelvis, people can get buttock and thigh claudication. And if it's further down, usually in the thigh, then we tend to see more calf claudication. And the pain, claudication pain, is pain that is only present with exercise. So it's not a pain that we would see at rest or at night. It's pain with exercise, typically with walking, climbing stairs, usually described as a Charlie horse or a very severe cramp. And it's entirely relieved by rest. It usually has a very kind of repeatable nature to it, meaning people can exactly pinpoint, they can kind of walk a similar distance every time before it comes on. They wait a fairly repeatable amount of time and then they can start again. And that's kind of the classic story with calf claudication. And then moving up would be those with chronic limb-threatening ischemia. This used to be called CLI, but essentially it is limb-threatening ischemia. And so it's those that have ischemic night pain, rest pain, or tissue loss. So the pain, when we talk about night pain or rest pain, we're talking about pain that's worse that's predominantly at night. It usually wakes people up from sleep. They can't sleep because of it. It happens routinely, pretty much every night. They're having to dangle their foot off the side of the bed. And the reason they do that is because, these patients who have ischemic night pain, they have such tenuous blood flow that just hanging their foot a foot lower off the bed or, a meter lower off the bed improves the blood flow just enough that it gets them out of pain. And so they'll do that routinely to help relieve their pain and get some sleep. And it's usually worse at night, mainly because their legs elevated. They're sleeping in a bed, and so they're not in a dependent position. And then rest pain is sort of the equivalent of night pain, but more so during the day, and typically pain involving the forefoot, toes, can involve the plantar foot. Not typically calf pain. And then tissue loss would be, these are wounds on the feet, ischemic ulcerations. So these are either wounds that are that not healing or progressive, certainly necrotic kind of distal wounds. So necrotic wounds on the tips of the toes is highly concerning for a vascular cause. So asymptomatic peripheral arterial disease. So we see this not infrequently. It's actually fairly common. And I pulled these are some of the AHA guidelines. And I also pulled a snippet from the Canadian Cardiovascular Society guidelines. And so the management of asymptomatic PAD is really risk factor modification. These patients should be initiated on lipid-lowering therapy, antihypertensive therapy, and their diabetes should be managed. Smoking cessation, of course. Preventative foot care. So these are diabetes. They should have regular foot exams, and at the least they should be aware of neuropathy and make sure that if they do develop any wounds, close attention is paid to them. If you look at the AHA guidelines, SAPT, which stands for single antiplatelet therapy, is a very weak recommendation. And if you look at the Canadian guidelines there, they actually recommend against routine antithrombotic therapy for patients with isolated asymptomatic lower extremity PAD. So we don't typically routinely initiate antithrombotic therapy for these patients. Certainly if they have a history of coronary disease or a history of stroke, or there can be other reasons for them to be on antiplatelet therapy, but the PAD itself often is not. And you ask about surgical intervention. Really, there's no role for surgical intervention in asymptomatic PAD. Why? Well, as we'll talk a little bit of it, our interventions carry risk, and if there really isn't a clinical or symptom benefit to be had, we're only really exposing the patients to the risk of the operation without any benefit, and that's why we don't do it. Next, we'll talk about claudication. So claudication, is obviously symptomatic PAD. The medical therapy is important. So we spoke about diabetes management, lipid therapy, blood pressure control, and then these patients have an indication for antithrombotic therapy. And most people are going to get aspirin 81 milligrams. Certainly reasonable to consider adding rivaroxaban. This is the compass dose, the low dose rivaroxaban, 2.5 milligrams twice a day, which gets paired with aspirin. Patients who would benefit from this, especially are those who have vascular disease and other beds. So they've had a history of coronary disease, a history of stroke or TIA. Those are the patients who especially benefit from it. Smoking cessation is critically important. Supervised exercise therapy. Unfortunately, there aren't a lot of great supervised exercise therapy programs around, but when I see patients who have claudication, I, number one, reassure them the pain they get in their calf or buttock or thigh, most commonly calf, is not a dangerous pain. It's they're not doing any damage, and I want them to walk. With the goal of, because we know that when claudicants walk, with time and sustained walking, they can actually increase their walking distance, and that you can improve somebody's symptoms quite significantly with an exercise program or just exercise in general. If you say, well, what is the long term? What happens to claudicants if you look forward? And I include this little snippet here, and I'll summarize what I think the key takeaways are. Number one, the vast majority of claudicants, about 80%, will have stable claudication. Most will not get worse, and very few, 1 to 3%, will develop limb-threatening ischemia. So actually, overall, it's a fairly benign problem. And what I mean by that is their chance of things getting worse, and certainly their risk of limb-threatening ischemia, is actually quite low. And that's especially true if they're able to quit smoking, which is really important. Now, it's not a benign problem because if you look at the cardiovascular morbidity and mortality, their chance of dying in the next 5 years from a cardiovascular cause, mainly this is MI or stroke, is 10 to 15%, and the risk of having a heart attack or stroke is up to 20%. So really, you look at a claudicant, their main problems are not necessarily their legs going forward, it's mainly their other cardiovascular risk factors and the history and the risk for MI or stroke. And that's why, medical therapy and anything that we can do to adjust that trajectory is critically important. And the role for intervention in claudication is definitely not first line. And in general, especially in my practice, I mean, there are variations between, different surgeons and how we practice, but generally I'm very conservative with claudicants. Why? Well, because I've just shown you that they have a fairly benign trajectory from a limb standpoint, like most are going to be stable, very few develop critical ischemia. And we actually know that when we start intervening on claudicants, that can actually cause harm. Well, because if you put a stent in somebody's femoral arteries, these stents have a patency, meaning that they'll stay open. Typically, it's kind of on the order of a few years, like somewhere between 2 to 4 years. And in certain scenarios, when these stents block, they can actually put people in a worse situation than they are now. And so that's why we have to be very conservative with claudication, because we don't want to make somebody worse in 3 years than they are now. So when we do consider interventions, we're selective. We usually prefer the endovascular interventions, which have faster recovery and are less morbid. We prefer to intervene on young patients who have a good risk profile and who have disabling symptoms, especially somebody who can't work or can't provide for their family because they're not able to do their job. And then when we do think about where the disease pattern to intervene on, we prefer to treat those that have aortoiliac disease. This is disease behind the belly button up in the pelvis, because those arteries are large and stents in that area stay open longer, so they have better durability. Next, I'll talk about chronic limb-threatening ischemia. So this is, we spoke a bit about ischemic rest pain, night pain, tissue loss, non-healing wounds, and the definition of CLTI, or you can think of it just as limb-threatening ischemia, is probably the simplest way to think about it, but it's 2 weeks of symptoms. It used to be called CLI, or critical limb ischemia. And there's been some changes lately. And the main reason for that is we're seeing more and more patients who have kind of a mixed picture of foot wounds and foot ulceration, where they have diabetes, diabetic foot ulcers with maybe a lesser severe burden of PAD. And so there's kind of a spectrum there where they have infection, wounds, and kind of mild to moderate PAD. And so that's why they changed the definition. But I think of it as limb-threatening ischemia. I think that's probably an appropriate way to think about it. Of course, on the same line we spoke about earlier, risk factor modification, antithrombotics, similar to claudicants, smoking cessation, and then revascularization for most of these patients. I think in terms of PAD pathway, so how I think about, how if I had to convey kind of my thoughts on how to manage somebody with PAD at a high level, as I said, I think arterial duplex is the mainstay. Initiation of medical management, often that's aspirin and a statin if they're not already on it, although often many are. If you have somebody with asymptomatic PAD, in my practice, I'm happy to see these patients. Oftentimes is a question regarding, are there symptoms related to their PAD? And that's not an uncommon one and a very reasonable one. But I think somebody with asymptomatic PAD would probably be a non-urgent referral, really at your discretion. Patients with claudication, again, I'm happy to see patients with claudication, of course. As would any vascular surgeon in Ontario or the country, I'm sure. These are usually seen non-urgently. Limb-threatening ischemia obviously is an entirely different ball game, and so these are urgent referrals, and especially if there are wounds present, that these will get triaged. At least in my practice or my colleagues' practice, we'll usually bring them to our wound clinic. We actually have we can even get same-day CT scans as an outpatient along with blood work, so we can usually work patients up quite quickly who have urgent problems. And so when we see a referral that has a wound and concern for limb-threatening ischemia, we can bring those patients to our wound clinic. Obviously, if somebody has acute limb ischemia, they should be referred to the emergency department. You ask, well, what's the difference between acute limb ischemia and chronic limb-threatening ischemia? And really the difference is the duration of symptoms. Acute limb ischemia has a duration of symptoms less than 2 weeks. I won't go too much into that because I think it's more of a relevant problem for the emergency department, but they should be seen in the emerge. And I think we see peripheral arterial disease. We have kind of atypical symptoms. Or trying to sort out, is this from the arteries? Concern. Always happy to see these patients. I wanted to talk a little bit about abdominal aortic aneurysms. Another fairly common pathology that we see. So abdominal aortic aneurysms, this is the most common location for an aneurysm in the body. It's located below the kidney arteries, but above where the aorta splits into the iliac artery. So it's right behind the belly button. The main risk factors will be smoking, getting older, male sex, hypertension, cardiovascular disease, and a family history. And you ask about screening, and yes, we definitely screen for these. Why? Well, the elective repair of an aneurysm is has a morbidity and mortality that is far lower than rupture. So when we unfortunately see patients with a ruptured aneurysm, we have to quote them about a 50% in hospital mortality risk, along with a substantial morbidity risk. And so if we can identify these patients before they have problems, before they rupture, then that's much to their benefit. So with regards to AAA screening, we now have a screening program. It recently started in October 2025, rolled out by Ontario Health. There are rolling patient notifications in the mail. I've seen some patients who've been notified, although I don't know. I don't think all of them have. I believe it's, as I said, it's rolling. Who should be screened? So certainly all men age 65 to 80. And the Ontario guidelines also recommend screening for all women 65 to 80. But they do note, especially those who smoke, have a family history of abdominal aortic aneurysm or a history of cardiovascular disease. I think historically, if you look at kind of the studies around this, the men are the higher yield screening patients for screening, just because they have a higher prevalence. The utility of screening in women has been kind of debated on different studies around the world, but at least the Ontario guidelines and recent studies here support it. So hopefully I mean, I've already seen a lot more screening done. Hopefully we'll continue to see that going forward. So if you look at the pathway, this is straight from the Ontario Health Guidelines. So patient gets a screening letter in the mail. They're instructed to visit their primary care provider. They get a referral for a abdominal ultrasound to rule out abdominal aortic aneurysm. And then depending on the results determines the pathway. So if it's an inconclusive study, usually the first thing to do is to repeat it. Sometimes bowel gas or technical factors can impair, visualization or make it non-diagnostic. If it's a normal study, it's done. If they have an ectatic aorta, we'll talk about that in a minute. An ectatic aorta is a blood vessel that's not a normal size, but it's smaller than an aneurysm. So it's kind of somewhere in the middle. And those warrant a repeat ultrasound in 10 years' time. If they have an abdominal aortic aneurysm, then they should be referred to a vascular surgeon. So this is kind of a summary of the findings that we just spoke about. So inconclusive suboptimal ultrasound, repeat. Normal results, so meaning the blood vessel is less than 2.5 centimeters in diameter. They don't need any further testing. They have a negative screen, and that's essentially good for the life of the patient. They don't need any further screening. If they have an ectatic aorta, so a blood vessel between 2.5 centimeters, larger than 2.5 centimeters, but less than 3 centimeters, they should have a repeat ultrasound in 10 years. It's quite a ways out, but that is what the guidelines say. And if they have an aneurysm greater than 3 centimeters, I think, it should be referred to a vascular surgeon. I know a lot of primary care providers, family doctors will watch small aneurysms on their in their practice. I wanted to talk about one thing that I see from time to time, and is talk about aneurysm length. So when we look at the aorta, the blood vessel in the tummy, the abdominal aortic aneurysm, it means obviously a 3D structure. There are different ways of measuring it. You can measure the diameter, measured front to back, anterior posterior, transverse, or you can also measure the length of it up and down craniocaudal. I think the important thing to realize about aneurysm length is that it has no bearing on rupture risk or treatment decision. And unfortunately, it gets reported on outpatient arterial or aortic ultrasounds occasionally, which often can be confusing. And I personally find it confusing too. And if you look, I pulled a snippet there this is from the Core Health, so it's a cardiovascular group in Ontario, but they specifically note the following. Given that the length of an abdominal aortic aneurysm often causes confusion and can be misleading, it is recommended that the length not be reported. And so I pulled a snippet. This is actually a patient I saw in my office this morning of somebody who had an abdominal aortic aneurysm ultrasound, and they did report the length. So you can see under findings there, the distal aorta, they've reported 3 numbers, one of which, is always the length. And you can see, if you look at kind of their template there, the first one is anterior posterior measuring 3.8 centimeters, transverse is 4.0 centimeters, and then the length is 7.2 centimeters. And then, in slightly confusing fashion, they don't actually call out the size of the abdominal aortic aneurysm in the summary. So I find that report confusing. You ask yourself, how big is the aneurysm? Has it grown? Is that 7 centimeter number concerning? It certainly seems large. In reality, that's the length of the aorta, and it has no bearing on rupture risk or treatment decision. In reality, this patient has a 4.0 centimeter abdominal aortic aneurysm, which is as we'll talk about in a bit, below the threshold for surgery and really just warrants ongoing surveillance. So I wanted to highlight that because I do see that from time to time, and yeah. So abdominal aortic aneurysms, well, we initiate medical therapy. These are statin indicated conditions. So often these patients should be on a lipid lowering therapy. Smoking cessation is really critical. We know that smokers have a faster rate of aneurysm growth. So if people can quit smoking, then that will reduce the rate of growth and potentially reduce the likelihood of them ever needing an operation, which would be ideal. Patients should usually be screened for other cardiovascular diseases. And then screening should be recommended for first-degree relatives. This is usually brothers, sisters, sons, daughters, because there can be a family history of abdominal aortic aneurysms, especially in those who smoke. So we spoke about the abdominal aortic aneurysm referral pathways. Less than 2.5 centimeters is normal, doesn't need further referral or testing. If they have an aorta between 2.5 centimeters and 3 centimeters, they should have a repeat ultrasound in 10 years. If it's greater than 3 centimeters, recommendation is for referral to a vascular surgeon. Most of these patients are going to have ongoing surveillance, which is dictated by the size. So the bigger aneurysms are watched more frequently than the smaller aneurysms. What you asked, what is our threshold for surgical repair? Well, in men, that's 5.5 centimeters, and in women, it's 5 centimeters. Why is it lower in women? Well, women have smaller blood vessels, and they're known to rupture at lower diameters. So that's why the threshold for surgery is slightly lower. If you see something about saccular aneurysm, so I put a little picture in the bottom right here of different aneurysm shapes. And what I'm trying to illustrate, if you look at the fusiform aneurysm, which is the one on the right, where you kind of see symmetric enlargement of the blood vessel, that's the most common shape of abdominal aortic aneurysms. But if you see a saccular aneurysm, which is on the left, which is most commonly what we see in the brain, but if you see that in the peripheral arteries or in the aorta, that's something that should be referred at any size because the natural history is less well defined and management is kind of more nuanced and often at smaller sizes for procedures. In my eyes, I think anyone with an aneurysm greater than 6 centimeters should have an urgent referral. There are also iliac aneurysms. I won't get into too much into the details about the sizes and things like that, but I think reasonable to refer any iliac aneurysm as well. I want to talk a little bit about venous disease, another common pathology that I see. In my eyes, I break down venous disease as occlusive, and then reflexive or reflux, the two different types. We won't talk too much about occlusive disease, but this is these are DVTs essentially, or DVT would be one type of this. So they talk about occlusive disease, it's either acute or chronic. You say, well, how could it be chronic? Well, when patients have, as you probably know, when patients have DVTs, often these clots do not clear, or there's evidence of chronic scarring or changes that persist for years, or often indefinitely. So DVT, this is deep vein thrombosis, obviously, as you know, and just, kind of at a high level, when we see femoral popliteal DVTs, most of these patients get at least 3 months of anticoagulation and a hematology assessment. For iliac DVTs, especially those that are acute, generally most of them should be referred to the emergency department. You say, well, why is that? Because there is some evidence that thrombolysis or procedures to clear the clot in iliac DVTs can be helpful long-term for patients, especially in young patients. So that's certainly a consideration. And these procedures are really only available within the first 14 days after onset of symptoms. Secondly, often these patients will be treated, at least initially, with low molecular weight heparin as well, as opposed to a DOAC. When we talk about more about occlusive disease, we talk about SVT. Something I see pretty commonly It's very common, far more common than DVT actually. Usually secondary to varicose veins. So these patients will often present with kind of a painful, red, tender cord-like structure, usually on the medial aspect of their leg, because the GSV is the most. Sorry for the disconnection.
That's okay. All good.
I'm going to resume here where I left off. Sorry about
Perfect.
that.
Nope, all
Can you
good.
see my slides okay? We're back where we were?
Yep, back where we were.
Okay,
Yep,
perfect.
perfect.
All right. Some office IT issues, so I guess we all know what that is like. Okay, so we're talking about venous disease. We're talking about superficial vein thrombosis or superficial vein thrombophlebitis. So common, usually secondary to varicose veins. I talked about the symptoms and kind of the location where it is. I personally find the thrombosis Canada guidelines are very helpful for this. And I included kind of the table here about how these are managed. So the bottom line is that the treatment of an SVT is so usually we consider treating acute SVTs, and the treatment decision is based on how close the clot is to the deep veins. So if it's close to the deep veins, less than 3 centimeters from the saphenofemoral junction or saphenopopliteal junction, that's where the superficial veins meet the deep veins, we often treat them as a DVT. If they're further than 3 centimeters away, which is usually most commonly the case, and if the length of the clot is more than 5 centimeters, then we treat them with kind of a modified dose of anticoagulation. There's some options mentioned in the kind of the chart below, but usually in my practice, that's 45 days of 10 milligrams of eroxaban daily. That's usually the easiest thing to prescribe. If the clot is a ways away from the deep veins and it's not very long, so less than 5 centimeters in length and further than 3 centimeters away from the junctions, usually we manage them without anticoagulation with kind of topical anti-inflammatories, NSAIDs, warm compresses, compression therapy. We usually do repeat the ultrasound if they are being treated without anticoagulation. The goal of the ultrasound is not to look for disappearance of the clot. It's to exclude progression and presence of a DVT. Because often, again, as I mentioned earlier with DVTs, like the ultrasound will show chronic findings in the clot. These will often be there indefinitely or forever. And so, I mean, we really rely on the outpatient ultrasounds to say, is this acute clot? Is it chronic clot? Does it look like it's been there for a while? You know, often we find chronic SVTs in patients who didn't know they had one when we worked them up for varicose veins or something like that. And you know, these patients don't get any treatment in my practice if it's found incidentally and it's chronic and there's no symptoms. I want to talk a bit about venous disease, and we'll talk about refluxive disease because this is obviously a very common pathology as well. We talk about reflux, that's really dysfunctioning vein valves. So the vein valves allow the venous blood to go up back to the heart, but prevent it from coming back down. these valves can fail or malfunction or not function properly for a variety of reasons. Reflux can be in the superficial veins or the deep veins, just like you can have a DVT or an SVT. You can also have a reflux in the deeper superficial veins. Symptoms, as I'm sure you all know, heaviness, aching, swelling, predominantly in the calf, discomfort, sometimes paresthesias, usually worse with standing and improved with walking or with leg elevation, usually better at night and worse at the end of the day, better in the morning when they first wake up. Patients can have complications from their varicose veins or from their venous disease, including bleeding, superficial vein thrombophlebitis. They can have skin changes or lipodermatosclerosis. I'll show you a photo of that, and venous ulceration, which is more advanced. So when we see patients who have venous reflux, we examine them, we assess their symptoms. A fair number of patients who have a documented reflux may have no symptoms at all or very minimal symptoms. Certainly, trial of compression socks is the first thing to consider. Patients often ask, well, how much compression should I wear? Generally, the recommendation, or my recommendation is for 20 to 30 millimeter mercury knee-high socks. These are prescription grade socks. I find these are kind of a happy medium. I think the challenging part with compression is often uncomfortable, difficult for patients to put on. So we're trying to balance the likelihood of patients actually wearing their socks and then so they can derive benefit versus, something really, really tight. So 20 to 30 is a reasonable choice. These socks, unfortunately for some patients who don't have drug plans or insurance coverage, they are quite expensive, usually around $130, $150 a pair. So there are over-the-counter 15 to 20 millimeter mercury compression socks that you can buy for usually around $30 at Costco, Shoppers, Amazon. These are better than nothing, but obviously the higher grade compression is usually more optimal. There are even higher grades of compression, 30 to 40, but in my experience, in my practice, these are just so difficult for patients to put on that very uncommonly used. When we're working up patients for venous disease and venous reflux, we usually get a venous duplex or a reflux study. Now, this is different than a DVT study, and as I sometimes see that I'll see patients who've been referred for an ultrasound, and the question is reflux, and then they get a DVT study. And so I think there are perhaps some ultrasound facilities that don't perform reflux studies. So that may be one thing just to be cognizant of, but we want to know their pattern and distribution of reflux. We want to know, is the reflux deep or superficial? Patients often ask about medications for venous disease. There are medications with evidence behind them. Probably the most common one would be Venexa. You can buy it over the counter at Shoppers. It's a micronized, purified flavonoid fraction, but the bottom line is there is evidence and RCT studies to show it helps with symptoms like swelling, aching, and discomfort. It does not make the veins go away and does not change the trajectory of the venous disease. When we talk about interventions for venous disease, for reflux, generally speaking, patients who have deep system reflux, we do not do any intervention on them. They are managed solely with compression therapy. A lot of patients with deep system reflux, some patients with deep system reflux will have that as the sequelae of a prior DVT. So the clot in the vein from years ago has permanently damaged the valves, and that's why they have deep system reflux. But there are really no interventions for deep system reflux. We can't fix these valves, and often, trying to intervene on these veins only makes things worse. For patients who have superficial reflux, there are procedural options. We're talking about the great saphenous vein on the inside of the thigh and calf, or the small saphenous vein behind the calf. There are surgical options. So surgical stripping is a very reasonable and available procedure. It's covered by OHIP, and certainly for young patients, it's a very reasonable option for treating their varicose veins. There are, as I'm sure all you know, other options for ablating these veins. So we can't fix the veins. We can't fix the superficial veins. We make them go away, and the blood is diverted through the deep veins, which have been confirmed functioning normally. So there are other ablative therapies like laser or radiofrequency ablation or glue. Unfortunately, in Ontario, these are all private, As I'm sure you know, there's a variety of private vein clinics. I mean, myself and my colleagues, but most vascular surgeons will offer this, but it's expensive and unfortunately often a barrier for patients. For varicose veins themselves, so when we're not talking about reflux in the great saphenous vein or the small saphenous vein, but just bulging varicose veins, treatment for these can include phlebectomies or injecting sclerosants. These are medications that make the veins scar down, which can sometimes be private or OHIP, depending where it's done. Spider reticular veins. So these are much smaller veins. So varicose veins, if you look at the textbook definition, is 3 millimeters in size. Spider veins and reticular veins, I've included a photo here, are much, much smaller. And these are really the domain of private interventions, usually liquid sclerotherapy or external laser. Not intervened on by all vascular surgeons, often done at vein clinics or by dermatologists. Again, often privately. I want to talk a little bit about venous leg ulcers. I see a fair number of these in my practice. So these are usually in the gaiter region, so the inside of the calf, most commonly, but they can also be on the outside of the calf. Generally, the initial management is compression therapy and wound care. I most commonly use Coban wraps. So these are nursing applied wraps. They come in a roll and they're kind of rolled on the leg. The benefit of the wraps is that you can apply bandages underneath and then put the wrap on top. Without, instead of trying to put a bandage on and then drag compression socks on there. Additionally, the wraps provide quite a high degree of compression, which makes them quite effective at healing venous ulcers. And so we facilitate this very commonly through home care. I think the main thing is patients who receive Coban or compression wraps, they need to have their ankle brachial indices documented. That's a requirement from home care. They will not put them on unless it's been documented. So that's one reason we measure ankle brachial indices in clinic, because it just makes things faster. But the other way would be to get an ultrasound as an outpatient outside of the hospital. Post-healing of a venous ulcer, patients are transitioned to compression socks, usually lifelong, because we know that compression is important for healing the ulcer, but also preventing its recurrence. So it's important educating patients around this. And oftentimes we'll do a reflux assessment, usually once their ulcer is healed. But sometimes if we're having difficulties with healing. And why is that? Well, we know that intervening on refluxing superficial veins so it decreases the risk of ulcer recurrence. So we know that the ulcers will either heal faster or have a less likelihood of returning if we intervene on an offending vein. So that's why it's a consideration. I mean, I think the challenge here and that I see quite frequently is that a lot of patients with venous ulcers are, perhaps elderly and frail, not good operative candidates, and may not be in a financial situation to afford some of the less invasive venous procedures. So that can sometimes be a challenge, but at the very least, it should be performed to look and see, at least assess the options. I wanted to highlight alternative compression options because I often see patients, and this is a discussion. Compression socks can be hard to put on, especially for elderly patients. So what are the other options? And then I was going to say the home care, the Coban wraps, which are the Velcro wraps, or not the Velcro wraps, the wraps that are applied for venous ulcers. Usually home care will only apply those while there's an active ulcer. So once the ulcer heals, the home care, I think obviously they're resource constrained. They're just not able to continue applying Coban indefinitely. And so there needs to be a plan to transition. And sometimes this can leave patients in a bit of a challenging situation where they can't get socks on. Home care won't provide Coban. What do they do now? So options are the following. These are two options that I most commonly use. On the right is tubular elastic bandage. So one of the trade names is TubiGrip. I have no affiliation with TubiGrip, but you can buy, it's essentially a roll of a fairly light compression hose that you can buy on Amazon. Home care also carries it. We apply it in clinic. You can apply it in 2 layers from the foot all the way up to the knee. It's fairly mild compression, but sometimes for elderly patients, this is exactly what they need. Usually you can reuse a piece for a week or two, washing it a couple times, and then it's discarded as the elasticity wears out. And that's often a good option for elderly patients, easy to put on. You can double it up in a second layer to get a bit more compression. I often see elderly patients with leg edema, and this is a pretty reasonable way to go. The other option on the left is Velcro wraps. These are actually now available through home care for free, which is new in the last year. So the specific model, again, I have no affiliation, Sigvaris Compraflex Velcro wrap, which is what the photo is there, and it's a wrap, or it's a garment that's pulled on and then tightened with straps to different levels of compression. Home care will provide these to patients free of charge. They do need their ABIs documented, just like per Coban. And they're usually a pretty good option. They're easier to put on. They're a bit bulky, so I've had patients complain about that. And the photo here doesn't show any foot piece, but there's also a foot piece as well. But they can be a bit bulky and difficult to wear with footwear, but they're covered. Unfortunately, home care will only provide one per person. So, if in a year or two, if the elasticity is starting to wear out or the garment's kind of reaching the end of its life, I've had issues getting a second pair for patients. But they can also be purchased as well. But it's nice that they're available through home care. Venous disease, when to refer. I think venous ulcers, of course, these should be referred. I usually appreciate if patients have an ulcer, that gets them triage faster, and I'll make sure I bring them to the wound clinic so that we can, get them started on compression therapy right away. Certainly those with complications, whether it's bleeding, healed ulcers, or significant skin changes or lipodermatosclerosis, so the dark thickening skin in the calf. And then those with symptoms, and especially those who are interested in intervention. I'm happy to see those patients as well, of course. And that's really all I had. I think it's probably been about 45 minutes. I'm happy to field any questions, either in the chat box or if anyone has anything. Yeah.
Amazing. Thank you so much. That was super thorough and really informative. We really appreciate all of that. I'll let people start writing their questions in the chat for you. And maybe I'll just get us started. I know in Durham region especially, we have a high rate of lower limb amputations. Is there anything, basically your entire presentation will be helpful to us on that topic, but what are some of the missed opportunities, or where could we be really focusing some of our efforts as a system to look at how do we resolve that and trying to reduce those lower limb amputations and preserve that functionality for patients? Any thoughts on that?
Yeah, I think if you look from an evidence-based standpoint, like prevention is probably the most important thing, right? So, whether it's management of vascular risk factors, probably diabetes being the most important one. Recognizing patients who have diabetes, managing those that do, the importance of foot checks and just patient education around, if you have neuropathy and you get a wound on your foot, that's a very serious problem that needs to be treated, quite urgently, because these things can progress very quickly. And I think anybody with, significant vascular risk factors that, certainly develops a wound or has concern for limb-threatening ischemia, like these patients should be seen quickly. I realize that can be difficult. From a Lake Ridge health standpoint, I realize the referral pathways in Lake Ridge are probably either Peterborough or Scarborough, I suspect, from a vascular standpoint. But I think, when these referrals get sent, highlighting the presence of a wound, and that will get patients seen much, much quicker. Yeah. It's often multidisciplinary, right? Even when we see patients with this, like I routinely see patients and will involve endocrinologists and wound care team. And I think it's just prevention. And if a problem does arise, kind of, prompt recognition and multidisciplinary approach.
Yeah, for sure. That's excellent. And I know, certainly a lot of the folks we see with those lower limb amputations have a lot of complex socio-demographic issues. Sometimes they're precariously housed, and so much harder to keep a wound clean and ensure dressings are changed appropriately and things like that if we can't deliver home care because there's maybe not a fixed address or things like that. Do you see that in your practice as well?
Yeah, I do. Absolutely. Like, sometimes it's frustrating because sometimes the patients who have the most concerning wounds are my perception of the biggest problem are the ones most likely not to show up to clinic or to, it's a challenge. It is. We all face it and struggle with it. Yeah.
For sure. But I think you made a good point. Just if we can get home care out to, some of those patients, and obviously some have those limitations, but anybody that can have those kind of team supports and wraparound supports and people that can go to them and do dressing changes and wound care. I know there's, I think there's foot care through home care as well, if I'm not mistaken, like diabetic foot care
I believe so,
is
yeah.
one of the services through home care. So wherever possible, I think that's a great person to bring into the kind of primary care team to work through that prevention piece.
Absolutely. And I think too, like, oftentimes the home care nurses, they have obviously a lot of experience. So, they'll recognize a problem before a patient will, and they'll send them to the emergency department if they're worried. And that can sometimes just get them connected with, and more people on the team that's necessary. And so that's a really valuable resource as well. So I agree.
Perfect. That's
Yeah.
great. And could you speak a bit about total contact casting? Like, is that something that you recommend as well, or the role of that?
Yeah. So total contact casting, it's so I mean the main evidence for total contact casting is around diabetic foot ulcers, and there is good evidence for it. It unfortunately is something that we see less and less frequently done because it's quite resource and time intensive. Usually these patients are casted like once a week, so but we do offer it in our clinic. I usually am not the one prescribing it. Like I work with a foot and ankle surgeon who has a very strong practice, Charcot foot, diabetic foot ulcers. And so he does a lot of total contact casting. So usually, if I see patients with a diabetic foot ulcer, we're assessing vascular status, looking at their glycemic control, managing wound care, and often I will have them seen by him. I'm fortunate to do it. He's just down the hall from me, so it's absolutely amazing. And so, but we do total contact casting amongst other offloading strategies. Like, Darko shoe is a pretty common and fairly simple, straightforward offloading method. But we also do a lot of air. We use air casts as well. And then there are orthotics and things like that are kind of more custom and more expensive as well. But it definitely has a role. I quite like it. I think it's great. It's probably underused. It's just it can be difficult. I think in my speaking with some of the cast techs that I work with, like the knowledge and ability to put these on is kind of fading a little bit. Like it's just not as commonly used as we used to, but it is a very good treatment for diabetic ulcers and offloading.
Perfect. Excellent. All right. Any other questions from the group? It was a very comprehensive and excellent presentation, Dr. Van Asseldonk. So thank you so much. You might see a few more referrals come your way from out our area. I know we don't have a great. Maybe I could be corrected on this, and you might know colleagues close by, but I don't think we have great access to vascular surgery specifically in Durham region. My understanding is it's your team at Scarborough, and then Peterborough has a team as well, and I think we have one surgeon coming from Peterborough once in a while to Lake Ridge, but I would say it is kind of a challenge for primary care to access the specialty for sure. So nice to know. I mean, Scarborough's not far, so nice to know about the multidisciplinary clinic you have over there for patients to access.
Yeah, I mean, I think you're spot on. I realize it's a challenge. My colleague and I are in the process of we actually have already started, but like recently of opening up some clinic time in Ajax, actually. So
Nice. Great.
hopefully we'll probably send out a mailer or a flyer via fax once we're a little more established. But essentially us traveling there to do a clinic much in the same way. I know some of the Peterborough folks come to Lakeridge, so hopefully that'll improve access. I mean, you know, we all do virtual care as well. Like I often see patients initially the first time, and then I'm happy to do phone calls and facilitate imaging close to home and things like that so that, you know, the commute isn't such a burden. But yeah, you're right. Like with complex wounds and things like that, we need the hospital resources, and for us, that's here in Scarborough. So I appreciate your challenge, and hopefully, you know, with time, partnership, we can make it better.
Absolutely. And when you do get set up, let me know. I'm happy to send out messaging to our primary care colleagues and get them notified of your referral path and all of that great stuff in Ajax. So that's amazing. Good to know.
Thank you very much. Thanks for having me.
Thank you so much for your time. Really appreciate it. And take care.
Okay, bye.
Bye-bye. For the rest of the group, just wanted to close us off with, again, we just ask that you please do an evaluation of today's presentations, and I'll put the link in the chat. On the screen right now is a QR code. So if you have any feedback, we'd certainly love to hear from you. It helps us to really try and make this suit your needs. That's why we're doing this, is to really try and match your learning interests and needs. And so if you could please fill that out, it's greatly appreciated. We will send out certificates for those main pro credits probably early next week. And this has all been recorded and will be uploaded to our YouTube page as well. So that's hopefully that's helpful. We are going to take a hiatus over the summer. So no education for July and August. We just don't think we can compete with everybody's vacation plans. So we will reconvene in September. So the next date is September the 25th. And so far, we're still solidifying and confirming presentations, but definitely going to have a presentation on managing hematological conditions by Dr. Lashman Vasantha Mohan. And we will also, we're just confirming, but very likely to have a presentation about addiction medicine and community resources from the Pinewood team here at Lakeridge. So that's that, and looking to see if we can book a third, or we have some other opportunities we're still investigating, but we have a little bit of time. So hope to see everyone back in September. And we thank you for being here today, and please fill out that evaluation. Thanks again, everyone. Take care.